So who is from PAT side? Is it Anjana or somebody else?
Sir, Dr. Anju, SR
Oh,
Pathology.
okay. Hi, Dr. Anju. So thanks for joining. Please wait for 2-3 minutes for the students to join. I can see 17 participants.
Okay,
Shall we start? We'll wait for a minute or two. Just we'll give them 2 more minutes.
start and go. मैम और सेल दो क्या पीपी डालता है क्या
So it's 1:02 already. So I think we can start. So let other people join as many they are able to join us. So today, good afternoon all. Thanks for joining this session. Hope you're all staying safe, doing well. So today we have a case study in hematology. So the case study topic is acute leukemia, especially acute lymphoblastic leukemia. So this is an interactive session. So I will share the screen and then discuss a few aspects of acute leukemia, including clinical history, clinical findings, on the lab investigations. So I hope we'll be able to interact. So when I direct questions, you can unmute yourself and then you can take part in the case study. Hope my screen is visible for you. So this is the case history. I think a short version of this was circulated to you. So here we have 12 years old male child, and the child is admitted to the hospital with complaints of progressive pallor and weakness. And this has been present for the past 3 months. And the child also has 2 episodes of epistaxis, lasting for about a week or in the last 1 week, and 3 episodes of fever. So let's start with Ishan Gupta. So Ishan, what do you think about case history?
Yes, sir. Sorry, I didn't hear you.
So from the history, what can you diagnose or what do you think is happening given this short case history?
Like in the morning we discussed, so the like pallor and weakness and fever are suggestive of some, like they can indicate some malignancy, but pallor indicates some like erythrocytopenia or something. And
Do you want to use the word erythrocytopenia? Is it commonly used or commonly can use something else?
sorry.
So instead of erythrocytopenia, can you use some other common term?
Anemia.
Yeah. So normally we don't use the word erythrocytopenia.
Yeah.
Use the word Okay. For other lineages, we use the word cytopenia.
Right. Right.
So what is the term in use when the WBC count is low?
Leukocytopenia.
Leukopenia, not leukocytopenia. Leukopenia, huh? Simple. And
Okay.
what is the term used when the platelet count is low?
Thrombocytopenia.
Thrombocytopenia. What is the term used when the RBC count is low or the hemoglobin is low?
Anemia.
Just anemia. Don't use the term erythrocytopenia.
Yes.
Okay. So, Ishan. Now we will
And
ask Anju.
this can be like some thrombocytopenia can be there or something because it's some nosebleed, right? So that can be there.
Why do you think there is thrombocytopenia?
Like the malignancy, so there can be a bone marrow involvement, and like this can lead to other cells like can get reduced in.
In the history which says that there is thrombocytopenia.
Sorry.
What is given in the history? So I have shown you one slide. So what is in the slide which says that the patient can have thrombocytopenia? What is the symptom of thrombocytopenia? That's why I'm asking. That's what.
Like I thought from the bleeding, this thing that because of the nosebleed, the epistaxis.
Okay. And what about fever? What do you think about fever?
Some like it can be due to some infection also, or like because of leukopenia, there can be like increased chances of infection and then resultant fever.
Okay. So there can be infection because of leukopenia or absence of at least normal neutrophils. Okay, good. Okay, good, Ishan. So, Anju is there? You can see the name. Kartikeya. Kartikeya is present?
Yes, I'm present.
Yeah. Kartikeya, so Ishan told that there is anemia, there is leukopenia as well as thrombocytopenia. So what do you call this condition when you have anemia, thrombocytopenia, and leukopenia?
So, pancytopenia, when all three are less.
Yeah, pancytopenia. Good. That's fine. So from the history, it suggests that there could be pancytopenia because you have symptoms which can be attributed to reduced cell length of all lineage. So, what are the conditions you think can give rise to these manifestations? What are the diseases which can lead to pancytopenia?
So there could be some deficiency in the bone marrow. So all the cells that should be present in the blood, they're not being formed. So it could be neoplastic disease of bone marrow.
Neoplastic disease of bone marrow. What are the neoplastic diseases of bone marrow that you know of?
Sorry, sir, could you repeat your question?
Neoplastic diseases of the bone marrow that you can think of. Can you name some neoplastic diseases of the bone marrow?
So there could be there could be metastasis of any neoplasm into the bone marrow, or like there could be infiltration of any bone tumor into the bone marrow that would result in pancytopenia.
So one is infiltration of other tumors, non-hematopoietic tumors. Okay. Can tumors of the bone marrow itself lead to all these conditions? Can lead to pancytopenia? Leave out other tumors metastasizing to the bone marrow. Can the tumors in the bone marrow can lead to pancytopenia?
Sir, it may because of like the pressure that would be applied by the neoplasm on the bone marrow, so it may result in.
What are those cancers or what are those neoplasms? What are those malignancies which is arising in the bone marrow can lead to this type of pancytopenia? Gagan, I can see Gagan Dalal's name. Gagan, can you tell us about
Sir, there can be leukemias, B cell or T cell.
Your voice is not very clear, Gagan. You have to keep the mic close to you.
Sir, there can be bone marrow aplasia. There can be neoplasms.
Okay, so that's bone marrow aplasia. So what do you call the condition with bone marrow aplasia? What is the common terminology used? Aplastic anemia?
Yes, sir.
So aplastic anemia, though it is condition which leads to pancytopenia, we use the term aplastic anemia to indicate bone marrow aplasia. That is the terminology used. Okay, so aplastic anemia, is it a cancer or not? Is it a malignancy or is it not a malignancy? Is it a malignant condition or a non-malignant condition? Lohit Ashwa?
Sir, repeat. Can you repeat, sir? थोड़ा skip हो गया.
So Gagan mentioned something about aplastic anemia. So aplastic anemia, what is it? Is it a malignant condition or a non-malignant condition?
Aplastic anemia is a non-malignant condition जिसमें bone marrow insufficiency होती है, maybe due to immune problem.
Maybe नहीं. This is due to immune condition. Okay. So can you tell us some malignant conditions which arise in the bone marrow?
Sir, acute lymphoblastic
Yes.
leukemia.
Okay.
Acute myeloid.
Yes, that's correct. Good. Acute myeloid leukemia. So these are the two important.
Lymphoblastic.
Lohit Ashwa, your signal is weak. I can hear your voice only intermittently.
Lymphoblastic leukemia, sir.
Okay. There's two diagnoses. Okay, Burkitt. Anything else? Okay. So from the history provided, we have some indication that the child is having symptoms which is related to insufficiency in the bone marrow. It is related to decreased red blood cells or anemia, which is leading on to pallor and weakness, and the child has bleeding symptoms, epistaxis, which is basically nasal bleed. So that again indicates decreased platelets, and the child also has fever, which is probably this could be due to reduced neutrophils. So next, the child is examined. On physical examination, the findings are given. There is marked pallor, and there is no cyanosis, clubbing, jaundice, or lymphadenopathy. Pulse rate is 110 per minute, respiratory rate is 25 per minute, and the abdominal examination is soft, no organomegaly. There are some precardial pulsations. There is a ESM present, and the same as examination appears unremarkable. So next we go to Pushwant. Pushwant, empathy.
Yes, sir.
Why do you want to do? What is the importance of lymph nodes? Of lymph nodes.
Hello. Hello.
Can you hear me, Pushwant? I can't hear you properly. We move on to Shreyas. Shreyas Agarwal. Can you tell me about the importance of examination of lymph nodes?
So there could also be lymphoma in this case. So if there is no lymphadenopathy, we can rule out lymphoma.
Okay, so you are saying lymphadenopathy seen in a case of lymphoma, so which is not present here. Okay, we'll come to that in a bit. So can you completely rule out a lymphoma if lymphadenopathy is not present?
So there would be other signs of lymphoma also. Some.
So okay, that's fine. So tell me some causes of lymphadenopathy. Tell me, name some diseases which have lymphadenopathy.
Sir, infectious diseases can have lymphadenopathy, for example, TB.
Okay, TB, then?
Or some other bacterial diseases.
What bacterial disease? Can you name some bacterial diseases? So okay, we'll come to that in a bit. So apart from infectious diseases, what other conditions can have lymphadenopathy? Ashwin DP, Orion Bansal.
Yes, sir.
Yeah.
So, any malignancy can have lymphadenopathy.
So what are the malignancies? Can you elaborate them?
So any like tumor that has metastasized to lymph nodes.
Like, can you give example? Any blood tumor means what type of
So
blood
like
tumor?
breast cancer.
Okay, so that is not a blood tumor, no? It's a solid tumor. That's a malignancy of breast tissue, not blood tissue. Okay, apart from that,
So there could be infectious causes like TB or HIV.
okay, then what about immune causes?
So autoimmune.
So what are the autoimmune conditions? So what is the most common cause of lymphadenopathy, at least in India? Aryan.
So I don't know.
Ishika Gupta.
So filariasis.
Filariasis. So the most common one is TB, isn't it?
Okay.
Infectious causes basically, and TB stands first. And filariasis again can cause lymphadenopathy. So you broadly classify it into infectious causes, malignant causes, then autoimmune conditions also can cause lymphadenopathy. Mycobacterial infections come first in infection in the infectious category. Then among tumors, it can be either primary lymph nodal malignancies like lymphoma, or more commonly they are due to metastasis or secondaries from other tumors. Can be a breast malignancy, can be a GI malignancy, it can be a lung malignancy, etc. Okay. And we go to Hardik Dayal. Can you comment on the heart rate in this patient? Hardik Dayal. Hemant Kandilia.
Yes, sir.
So, can you tell me about the heart rate in this patient? What do you think?
It's tachycardic. Maybe it's because of the maybe it's of a pancytopenia, because we are also seeing a pallor, right? So that is pointing towards an anemia, and probably the heart is trying to compensate for the reduced oxygenation to the tissues.
So it's mainly due to anemia, not pancytopenia.
Mainly due to anemia. The anemia is the main positive factor.
Okay, what do you think about the respiratory rate?
Same, it's increased. Like in an adult, it should be like 12 to 16, but it's like 25 per minute. So it's again for that reason, the oxygenation. It's trying to oxygenate whatever blood cells are left. So it's trying to do it more, and that's why it's increased.
Okay. And here, the abdominal examination did not show any organomegaly. So can you?
So that's usually if we are suspecting any malignancy in an advanced stage, then we notice an organomegaly of mainly of the spleen or the liver. But here it's not this scale, so maybe it's not a very advanced case of a disease.
So can you tell me some conditions which have splenomegaly?
So I'm not exactly sure. It's ALL and CLL maybe. Because that are the cases found the OPD ones, but not.
Hematological conditions. What are the non-hematological conditions?
What are the
non-hematological conditions?
Infection with Kala Azar also.
Okay, then. So in hematology, what are the causes? Under hematological conditions, so can you name some conditions which have massive splenomegaly? The spleen is usually enlarged to a great extent.
Is it ALL, CLL?
You can get splenomegaly in ALL and CLL, but usually these are not very.
These are not massive.
They're not massive.
Sir, hereditary
sickle cell anemia, things like Gaucher's.
Yeah. Who is Bobby? This is Bobby or Hemant? Who's speaking? Hemant. Okay. Hairy cell leukemia. Yes, that's right. So in hairy cell leukemia, you can have very big splenomegaly or massive splenomegaly. That's correct. Then
Beta thalassemia, sickle cell anemia. In infiltrative diseases like amyloidosis and Gaucher's.
Yeah, in storage disorders, you can have the big splenomegaly, and in beta thalassemia, it's usually moderate. But again, when the hemolysis is severe, you can get massive splenomegaly. So, any other conditions?
Lymphoma.
What type of lymphoma? Next, we'll go to Hardik. Let's see, Hardik Bendale can answer. Hardik Bendale, can you add on some conditions to this? Of massive splenomegaly seen in hematological patients. Shubhra Jyoti Mondal.
Some sort of disorders involving the flow of blood to the spleen.
Sorry,
can lead to congestive spleen.
Congestive splenomegaly. Due to what?
Like there can be some sort of conditions like Buck-Chiari syndrome can be there, and there can actually be generalized cases of blood all over the body, secondary to any heart failure or so.
Even a splenic vein thrombosis in terms of congestive.
Say that again.
Splenic vein thrombosis.
Splenic vein thrombosis can lead to mild splenomegaly, not the massive. Okay. What about CML, chronic myeloid leukemia? Do you get splenomegaly?
Alongside features where it can have an infection.
Like AML can also.
Okay.
So who is speaking?
Could portal hypertension cause splenomegaly?
Yeah, portal hypertension can cause splenomegaly, but usually mild to moderate. But that's a non-hematological condition, isn't it? It's a primary liver disease. Okay. And what about primary myelofibrosis? Or myelofibrosis? So primary myelofibrosis also can lead to moderate to massive splenomegaly. So there are a lot of conditions which can cause splenomegaly. Conditions like high-cell leukemia, chronic myeloid leukemia, primary myelofibrosis. All these conditions cause significant or massive splenomegaly. Other lymphomas and leukemias like CLL, chronic lymphocytic leukemia lymphoma, or even other lymphomas like follicular lymphoma, diffuse large B-cell lymphoma. These also can result in splenomegaly, but in that case, the splenomegaly is usually mild to maximum moderate. And other causes of red blood cell destruction, hemolytic anemias, for example, autoimmune hemolytic anemia, or thalassemias, especially beta thalassemias. In that conditions also, the spleen is enlarged. Again, it can be mild to moderate splenomegaly. Okay. Next, there is ejection systolic murmur that is again due to hyperdynamic circulation, and CNS in this case is unremarkable. So next we did some blood investigations, and then the results are given here. Hemoglobin, TLC, platelet count, and findings of peripheral smear. We'll come to the bone marrow. So Shailesh Kumar.
Yes, sir.
So how do you interpret the hemogram values given to you? Just say
Sir, hemoglobin level is low.
What is the hemoglobin level?
Severe anemia.
Severe anemia. So what is the normal hemoglobin level, and how do you classify anemia?
Sir, a normal level would be 13. 12 to 13.
It's a range.
Sir?
So when you are saying normal values of hemoglobin, is it a single number or you want to give a range?
Sir, it will be in a range.
So what is the range?
It will be 13.5 to 17.5 in male.
So does it differ with the gender, male and female?
Yes, sir. In male, it will be 13.5 to 17.5, and in female, it will be around 12 to 15.5.
So, who has given this cutoff value? Which criteria is this?
Maybe WHO.
WHO. Okay,
I'm
sir.
not sure.
Based on age.
I'm not sure, sir, but we generally do it by gender.
Which one? Male and female. Gender is one criteria. We will ask if Pura Shivani Srivastava can say about the normal values of hemoglobin.
Yes, sir.
Yeah, so can you tell us the normal ranges of hemoglobin in different categories?
For Indian male,
Above
12 is considered normal.
Maybe a bit louder. Your voice is not very clear. Please be a bit louder. You can bring the mic.
For an Indian male, a value above 12 is considered normal, and for Indian female, a value above 11 is considered normal.
Okay, what about children? Jamula Arun Yadav. Ashish Kumar Meena. Prathamesh Raphade. Many people are there. Logged in. Tejavat Sharat. Atyam Sai Praveen. Hardik Gupta.
Yes, sir.
Yeah, Atyam. So we are talking about normal ranges of hemoglobin. Can you
Yes, sir.
level of hemoglobin?
Sorry, sir. Could you repeat it?
Can you classify the severity of anemia based on the hemoglobin level?
Sir, between 8 to 12 is mild anemia and less than 8 gram per deciliter is severe anemia.
So what is severe?
Less than 8.
So there is only severe and mild, there is no moderate.
I don't know, sir. I'm not so sure.
Okay, so we'll come to that. So what do you think about the TLC, total leukocyte count? Is it normal, low or high?
Decrease it, sir.
Okay, so what is the normal leukocyte count?
6,000 to 8,000 per cubic millimeter.
6,000 to 8,000. What about the platelet count?
It is also reduced.
What is the normal platelet count?
150,000.
150,000 to give a lower range and upper range. 4 lakh. है ना?
Yes, sir.
So what do you expect? So this is a patient with severe anemia and leukopenia.
Pancytopenia. This is indicating pancytopenia, sir.
So in this case, you do a peripheral smear examination. So what all you see in the peripheral smear examination? What all you look for?
We look for the size of the RBC and the shape of the RBC, if there is any anisocytosis, anisocytosis, and any immature cells like lymphoblasts or erythroblasts, and different granulocytes and the differential counts.
So what specific type of cell will you look for in this scenario?
I look for lymphoblasts or myeloblasts because
basically you look for blasts and try to identify the type of blast.
Yes, sir.
Okay. Okay, that's fine. So how do you take the sample for a peripheral blood? So you take arterial sample or venous sample, a capillary sample?
So we generally take from the fingertip.
So one you can take it from the fingertip, that's fine. And what is the other type of sampling? So taking the sample for CBC or a sample.
For CBC, we generally take blood from median cubital lymph.
So you take from median cubital. So that's a venous sample. So can you make a peripheral smear from the venous sample? Or no?
Yes, sir.
You can also make peripheral smear from the venous sample while you're taking the sample or from the anticoagulated bile also. So bone marrow aspiration was done. So let's see who's lost from through general. Jindal is there. Bruti, which was Stacey?
Yes, sir.
Hi, Bruti. So, what is the site from where you can do a bone marrow aspiration?
Sternum, iliac crest means bone, pelvic bone.
Iliac crest, pelvic bone. So, which part of the iliac crest? Whole throughout the iliac crest, or we want to? There are some specific points from the iliac crest.
I think iliac tubercle, maybe.
Iliac tubercle.
I'm not sure.
Which is the most prominent part of the iliac bone posteriorly? What is PSIS?
Posterior superior iliac spine. Yes.
Yeah.
PSIS.
Most prominent and subdivided part posteriorly. It's easily accessible. Yes. The difference. So, where do you do a bone marrow biopsy? With you, it was. Abhinav Agarwal?
Yes, sir.
So, what is the difference between a bone marrow aspirate and bone marrow biopsy?
Sir, in aspirate, we mainly take the fluid in the bone marrow, and in biopsy we take tissue, a sample of the tissue inside the bone marrow to see all about cellularity, fat content in the bone marrow, everything. For that we take biopsy, and for making if aspirate can work, then we first go for aspirate, but if we cannot get aspirate, then we go for biopsy.
In a little bit detail sometime later. So, as you said rightly, in aspirate you take the liquid sample. These are used for making bone marrow aspirate smears. In biopsy you take a small piece of with attached bone marrow. So, this is basically a solid tissue. Yeah. Both have their specific uses. So, we'll discuss that in some time. This is the bone marrow aspirate morphology. So, let's search for the Kumar. Saraswati Kumar is there. So, Hardik Raj. Alok Singh. Rohit Raj. Abin Antony.
Hello, sir.
Is around.
Yes, sir.
Yeah,
Sir, could you repeat the question, please?
So, can you see the screen? There's a picture in the. Yeah. So, what do you think? Can you give your comment? Can you say what you can see on the screen?
Sir, these are not normal cells in the blood. These look like blasts, sir, to me.
Okay. Okay, very good. So, these are not normal cells and they look abnormal to you. And you think they are blasts. That's nice. That's very good. So, what are all the normal cells that you can see in bone marrow?
All the progenitor cells, both erythroid and myeloid progenitors.
Okay, so what are the erythroid progenitors? So what do you call them? Erythroblasts.
Erythroblasts.
So, okay, so what are the stages of erythroblasts?
one basophilic stage, orthochromatophil, polychromatophils,
Yeah.
reticulocytes, and mature RBCs.
Okay. Yeah. That's good. That's correct. So we have basophilic, polychromatophilic, and orthochromatic red blood cell precursors or erythroblasts. Then you have nucleated RBCs, and finally reticulocytes before becoming a mature RBC. That's correct. So that is for the red blood cell lineage. What about the granulocytic or myeloid lineage? What all cells you see in the granulocytic lineage normally? Who is the most immature cell?
I'm not sure, sir. I'm not sure.
So it is a stem cell or a blast, isn't it? And it gives rise to a promyelocyte, and then a myelocyte, metamyelocyte, then band form, then a neutrophil. Okay. So what is the precursor of platelets?
Megakaryocytes.
Yeah, megakaryocytes. So you can see megakaryocytes also in the bone marrow. So you can see the precursor of all three cell lineages in the bone marrow. You can see erythroblasts, the different stages of erythroblasts. You can see megakaryocytes, and you can see different types of granulocytic lineage precursors, starting from blast, promyelocyte to metamyelocyte, etc. Okay, so in this picture, though it is a bone marrow aspirate, we are not seeing all of them. We are seeing just one population. So next we go to Audiamon. Audiamon is there. Amisha Karna. Amisha Karna. Chaitanya Gupta. Ashutosh Sethi.
Yes, sir.
Yeah, so question is for you. How will you describe the morphology of? So I have a picture here. So how will you describe this cell? So there are this similar looking cells. You have RBCs and then you have this cells which are relatively similar to each
Not
other. Can't hear me? So
these are
can you
not. These are not differentiated in any form, like nuclear, no cytoplasmic is there, so might be that pre but pre-erythroblast, like the first stage of pre-erythroblast or no, erythroblast. No. First stage of myeloblast differentiation.
About the type of the cell, just describe the cell. So when you say the cell, what are the characteristics taken into account? First you mention the size of the cell, isn't it? So it is a small cell, large cell, medium-sized cell.
Compared to RBC.
Compared to what? Which cell is used as a comparator? RBC or something else?
No, sir. The cells are comparatively 2 times or 2.5 times larger than the surrounding RBCs. So these are of WBC family. And
what is the problem with comparing with? So you compare it with lymphocytes, mature lymphocytes. Not with.
So with RBC is the standard. Like we compare 2 times or 2.5 times of the RBC size. Like so that we determine whether it
anemia. If you compare it to RBCs, the RBC size itself is not constant, isn't it? The RBC size can be low, the RBC size can be larger, that can be lymphocyte.
Right.
So whereas the size of a lymphocyte is constant. Size of a lymphocyte and RBC are same, small lymphocyte and RBC. But the problem is if you have some iron deficiency or something, RBC size can reduce. So okay, that's fine. So when you say compare it to RBC or a lymphocyte, if it's present, and then you can say it is a small size cell or a large size cell, and you can make the size comparison. If it is 2 times bigger or 3 times bigger. Okay, then what are the other things you see? One is size. Next, so what about the NC ratio? What is NC ratio?
NC ratio. NC. No, the cytoplasm is very less as compared to nucleus. So the cell is not well differentiated, and there is also no cytoplasmic processes, and no granules.
High NC ratio or low NC?
High NC ratio.
Right. So high NC ratio meaning the cytoplasm is less in amount, isn't it? Okay.
Not differentiated. Okay.
Differentiation is fine. There's no differentiation. So what about the cytoplasm? What are the things you see in the cytoplasm?
The granules and those there is the spikes.
So granules or no?
Granules are absent.
They're agranular. So you said only agranular, and the granules are not there. And what about any other structure in the cytoplasm? You look for OR rods, isn't it? OR rods would be myeloid blast. So that is another thing you see.
The OR bodies.
OR rods, OR rods. OR rods. OR rods.
These are of lymphoid family. Yes.
So they appear like lymphoblasts. And you have to look for presence or absence of nucleolus also. So it is nucleolus is a structure which is present within the nucleus, light colored structure around. Okay, so we'll go to Dhananjay. So we will see how to describe the morphology of blast. Dhananjay is that? Dhananjay Chandel. Swapnil Kumar.
Yes, sir.
Yes, Swapnil. So, okay, we did mention about the bone marrow biopsy and bone marrow aspirate. And the advantage of bone marrow biopsy is you can do immunohistochemistry extra. And bone marrow aspirate, it being a liquid sample, you can subject it to flow cytometry. So, Swapnil, can you tell us what other tests will you do in a suspected case of acute leukemia? So far in this case, we have done hemogram, we have done bone marrow examination, we have done bone marrow biopsy. So what are the other tests which we can do in a case of acute leukemia?
Sir, we can check for liver function test and RFT, sir, because leukemia can cause problems in other organ systems too.
Okay.
And we could also take. Yes, sir.
Yeah, tell me, continue then.
We could also do a ECG.
Specific for activity, for diagnosing and classifying.
So means other investigation we could do on the basis of rest of the symptoms.
Your bone marrow aspirate sample, your bone marrow biopsy sample. With this, what are the tests that you can do? So how do you know whether it is a B lymphoid or a T lymphoid leukemia? T lymphoblastic leukemia or B lymphoblastic leukemia? What test is needed for this? Discuss this in the morning session today.
We do flow cytometry and immunohistochemistry.
Yeah, okay. So you can do flow cytometry and immunohistochemistry.
Flow cytometry.
And can you check the genetic status? So these are the tests we do. So we do the complete blood count, examine examination, bone marrow aspiration, biopsy, immunohistochemistry if needed. We do cytochemistry. We'll come to that in a bit. We do flow cytometry and then genetic studies, including cytogenetics and molecular genetics. So, Atyam Sai Praveen.
Sir.
Yeah, so the patient has a mediastinal mass. What are the causes can you think of? What are the diseases which can present with mediastinal mass?
Thymoma.
Okay, thymoma is one. Ishan Gupta.
Yes, sir.
Cause of mediastinal mass.
Like there can be some maybe some lung pathology which has like gone outside.
Problem in the lungs.
Sorry.
Lung pathology will have problem in the lungs, no? Maybe you want to have mediastinal mass.
Like it has reached up to the mediastinum, like something which has grown out, or some tumor which has grown outside and reached the mediastinum.
One is thymoma, that's fine. Can any lymphoma, leukemia present with the mediastinal mass?
I'm not sure, sir.
So, ask Anju is there? Anju or Kartikeya?
Yes, sir. Kartikeya, I'm here.
Yeah, yes, okay.
So there could be some malignancy in the thymus or thyroid, or if it is posterior mediastinum, there could be some tumor in the spinal cord, like related to nervous system. Apart from that, there could be metastasis from other parts of the body in the mediastinum that could form a mass.
What are the hematological malignancies?
Sorry, sir, could you repeat your question?
What are the hematological malignancies that can present with the mediastinal mass? Lymphoblastic lymphomas, especially T for Tata, T lymphoblastic lymphomas, they frequently present with a large mediastinal mass. And sometimes you can have primary mediastinal lymphomas, the large basal lymphomas, Hodgkin's lymphomas can present with the mediastinal mass. So these are the commonest hematological malignancies present with the mediastinal mass. And apart from that, you can have non-hematological malignancies also. You can have metastasis to lymph nodes. You can have germinomas there. You can.
Excuse me, sir.
Yeah, tell me. Yeah,
sir, when we say a mediastinal mass, is it grossly visible, or is it become visible on any sort of radiograph or imaging?
Both. So normally, how do you diagnose a mediastinal mass? So what are the clinical features of a patient with a mediastinal mass? Kevin.
Asymmetry, any sort of asymmetry.
Okay, asymmetry where? What? Just asymmetry?
Just asymmetry, just asymmetry.
Okay, then can you think of any syndromes associated with mediastinal mass, large mediastinal mass?
Horner syndrome.
What is that?
The mass presses on the sympathetic trunk,
okay.
causing which can cause ipsilateral pupillary ipsilateral pupillary meiosis, decreased sweating, ptosis, etc.
Okay, good. That's one. Other thing. What is superior vena cava syndrome or SVC syndrome? So when a large mass is present, it exerts pressure on the superior vena cava. So the blood flow back into the right side of the heart chamber is reduced. So it leads to engorgement of the upstream blood vessels, leading to swelling of the face, upper trunk, dilated veins over the upper chest. So that is also a manifestation of mediastinal mass, and that is a medical emergency. You have to treat the patient immediately. Okay. So, Loitas, what is a myeloid sarcoma? Can you tell us what is myeloid sarcoma? What do you understand by the term myeloid sarcoma? Loitas is the Pushwant empathy?
Yes, sir.
Yes, because, what is a myeloid sarcoma? Ashwin VP. Orion Bansal.
Yes, sir. So myeloid sarcoma, sir, is so maybe a proliferation of the myeloid precursor cells, that damage the surrounding tissue.
Okay, so what proliferation of myeloid precursors in the bone marrow? Where does this proliferation occur?
Sir, bone marrow.
Bone marrow. So bone marrow में फिर what is the difference between an acute myeloid leukemia then? Where does acute myeloid leukemia proliferate?
Sir, maybe outside the bone marrow, extramedullary.
Yeah, so it is proliferation of this myeloid precursors, immature myeloid cells. Most of the time it is myeloid blast outside the bone marrow and peripheral blood, and presenting as a mass lesion, or presenting as a tumor in the gums, tumor in the brain, the extramedullary tissue. So normally, they're present within the bone marrow and peripheral blood. So if they proliferate within the bone marrow and peripheral blood, we call it a leukemia, or an acute myeloid leukemia, if it's a myeloid cell. When it's outside the bone marrow and peripheral blood, presenting as a mass lesion, then we call it a myeloid sarcoma. So when we make peripheral blood smears, or when we make bone marrow aspirate, or even biopsies, we stain them. So what is the stain used for peripheral blood? Ishika Gupta.
Sir, Romanowski stains.
Okay, good. Romanowski stain. Can you name some Romanowski? So Romanowski stain is a single stain, or it's a group of stains?
A group.
Group of stains. So can you name some stains?
A group of stains.
Okay, good. Can you name some stains?
Sir, Leishman stain.
Okay.
Jimsa stain.
Okay. What about Jenner stain? What about May-Granville? So all these are types
Yes,
of
sir.
Romanowski. So you mentioned Leishman stain and Jimsa stain. What about Jenner stain?
Yes, sir.
May-Granville stain? They are also Romanowski stains, and they can be used
yes.
for peripheral. So what is the stain you use for staining bone marrow? Is the peripheral blood as bone marrow? अलग करोगे या सेम करोगे? So it's the same stain or different stain? Hardik Dayal, Rishika can answer. Yeah, Rishika, answer.
The supravital stains.
Supravital stain. No, we don't use supravital stain. So where do you use supravital stain? So you don't use supravital stains. The same stains you use for peripheral blood can also be used for staining the bone marrow aspirate because both are smear. In peripheral blood also you make smear aspirate, whereas in bone marrow aspirate also you make smears and aspirate. So both you can use Romanowski type of stains. Hemant Kandilia is there. Hardik Bendale. Subrajyoti Mondal.
Yes, sir.
So we are talking about the stains used for different types of samples. So what is the stain used for staining a bone marrow biopsy?
Not very sure, sir, but certain kinds of Varanowski stains are only used. We can also use an HNE stain.
So you can't use Romanowski stains. You have to use a H&E stain. Only H&E stains are used for biopsy. Okay. So Shailesh Kumar Dora.
Yes, sir.
So can you see something on the screen? So can you identify the test? So there is a picture of the result of a test which is done in this patient. Can you identify the test?
Sir,
What type of
cytochemistry.
Cytochemistry. No, it's not cytochemistry.
Immunohistochemistry. CD markers, sir.
So CD markers are there. So what are the tests which use CD markers?
Sir, flow cytometry.
Yeah, good. So this is a flow cytometry, or rather the plots are the results of flow cytometry. Okay. So what is the difference between flow cytometry and immunohistochemistry? So last Gura Shivani Srivastav. Gura Shivani Srivastav, can you tell us the difference between IHC and immunohistochemistry and flow cytometry? Jamula Arun Yadav. Ashish Kumar Meena. Prathamesh Rokade. Tejavat Sharad. Atyam Sai Praveen. Hardik Gupta. Ruchi Uttas Sethi.
Yes, sir.
So, what is the difference between immunohistochemistry and flow cytometry? What is the common feature? What are the differences? So, the two different
Sir,
types of
in immunohistochemistry, we basically put some enzymes like immunoperoxidase, for myeloperoxidase, MPO, and it stains particular type of cell. And in flow cytometry, maybe there is some fluorescence. We add something which show the fluorescence for CD markers.
So in flow cytometry, like we pass the cells in a single row and we measure the transmittance angle, like angle at which the light is deviated, and by that.
It was bone marrow aspirate or bone marrow biopsy. Which type of
So flow cytometry is for bone marrow aspirate and histochemistry is for bone marrow specimen, tissue sample.
So flow cytometry is a liquid sample. So it's a bone marrow aspirate. And for immunohistochemistry, you use a bone marrow biopsy section or a solid tissue. So both of these markers tell us about, both of these tests tell us about the presence or absence of certain markers like CD markers. They try to characterize the tissue based on some immunological markers. This could be CD10, CD19, CD3, CD5, CD34, etc., etc., etc. So in immunohistochemistry, we look at the slide. So the marker is present through an enzyme in this picture, whereas a fluorochrome is attached to this antibodies in the case of the flow cytometry. Okay. So can somebody tell me about the markers which is specific or indicate a B lymphoid lineage or T lymphoid lineage? Abhinav Agarwal.
Yes, sir.
So can you tell me about name some markers, B lymphoid markers, B lymphoid lineage markers?
Sir, for B lymphocyte, we can do CD19, CD10, PAX5, and for T, we can do CD1, 2, and 5.
Okay. What about CD3?
Sir, for T only.
CD4?
CD4 is also present on T cell.
CD5?
Means CD5 is on T cell.
CD7?
T cell.
Okay.
8 also T cell. Means those which are in unit digits are mainly for T cell, and those are in double digit, and 10 also are for B cell.
Okay. So, what about immaturity markers? What are immaturity markers? Do you understand the immaturity markers?
Sir, those for stem cell, I think.
Yeah,
marker for stem cells.
The present in blast, very early stages of
yes, sir.
Cell development. Those are called immaturity markers. So it helps to identify the immature cells present.
CD34. Sir, it is only what I know, one marker. CD34
is one. Good. So we'll go to Rohit Raj. Rohit Raj is there?
Yes, sir.
Yeah, Rohit, there's a picture on the screen and you have to identify what type of test it is. Amisha Karna.
Karyotype.
Okay, good. Karyotype. So it's karyotype by cytogenetics analysis. So what do you see? Basically, what is the test used for? What do you see in a karyotype? What are these?
The total number of chromosomes, any triploidy or deletion.
Yeah, good. So basically, it's a test for looking at the chromosomes. So you can look for the number of chromosomes present. You can look at the structure of chromosomes. So if there is anything wrong with the number or structure, so you can pick them up. number meaning the numbers can be higher than what is normally expected, as in hyperploidy, or the number of chromosomes may be lost, and then the numbers can be less than what is expected. So that is called hypoploidy. And then there can be some structural abnormalities like translocations, in which the chromosomal material between two chromosomes is swapped or interchanged. And there can be loss of chromosomal material, which is called deletion. So all this type of chromosomal abnormalities, which are very common and even diagnostic in acute leukemias, this can be picked up using karyotype or cytogenetic examination. So, Ashutosh Sethi, what is this test? Ashutosh is here. No. Go to Swapnil Kumar. Swapnil is here. Shreyas Agarwal. Yes. Yes. On the screen, can you identify what type of test it is? Swapnil.
No, sir.
Flow. Oh, so we already seen flow. So we lost somebody else. Shreyas, Gagan Dalal.
Is this immunofluorescence?
Gagan, you are not audible. Be a bit loud. Voice.
Sir, immunofluorescence?
Immunofluorescence. No, it's not immunofluorescence.
Sir, is it fluorescence inside hybridization?
Yeah, that's correct. So this is FISH test. FISH. Fluorescence in situ hybridization. So what is FISH? Maybe.
You add a fluorescent molecule along with a complementary DNA you want to check for, and you allow it to bind to its complementary chain. Then we look under we look under ultraviolet radiation for fluorescence.
Okay. So basically what we do is we look for specific chromosomal regions. So this can be normal chromosomal sites or abnormal chromosomal sites. So what we use fluorescent probes. What does fluorescent probe mean? The probe has some fluorescent material attached to it, and it has a probe. So what is the function of the probe? The probe binds to a specific part in the chromosome. So it could be long arm of chromosome 2, short arm of chromosome 5, or a specific gene in a particular chromosome, for example, a BCR gene or a PML gene, or a fusion product like PML fusion. So you choose a probe which is specific to a specific chromosome or a disease, and it binds to that specific part of the chromosome. And that is the that's the job of the probe. So the probe is attached to a fluorescent molecule. So fluorescent molecule is what we see under the fluorescent microscope. So you make these fluorescent probes for us under a certain wavelength, and then you look for them under the microscope. For example, here you can see the green signal here. This is the centromere. So basically, it is a probe which is a centromeric probe, and it has a green fluorescent signal. So when it is present, it means these two chromosomes centromere are preserved. Again, you can have this red telomeric probes here. So it means that this is directed towards the telomeres, and the signal is in red color. So basically, you look at the type of signals, you count the signals, and then you identify the abnormality of the chromosome. So this is FISH or fluorescence sensitive hybridization. So next is that Dhananjay is there? Dura Shivani. Srivastava. So among acute lymphoblastic leukemias, which is common, B or T?
B, sir.
B. So what is the proportion of B versus the proportion of T?
85% and 15%.
Yeah, so 80 to 90% or 85% nearly are DLL. And TLL accounts for roughly about 15. So you go to Ishan, once again Ishan Gupta.
Yes, sir.
So there is a picture and there is an arrow. There is something drawn
Sir,
up by the
inside
arrow.
cytoplasm of the blast, there's a like rod-like structure which is called as OR rod, AUER.
So OR rod, that's correct. So OR rod indicates the blast is a myeloblast. Okay. Next is Kartikeya.
Yes, sir.
Yeah. What is this picture? What does this picture show? What is this cell?
So, premyelocyte. Promyelocyte, sir.
There is no premyelocyte, it's a promyelocyte. Okay. So,
Yes, sir.
Lohitashrva.
Yes, sir.
What is this cell? Can you make a diagnosis based on this? What is inside this cell?
Sir, these are Auror's bodies only in a lot of Auror body are
There are multiple Aurors present within a single cell.
faggot cells, sir.
Yeah. So what does this indicate? What is the diagnosis if you see faggot cell or blast cells with multiple Aurors? APML, acute promyelocytic leukemia, or AML-M3. Okay. So these are some plots of blasts showing CD34, CD117, CD33. So these are myeloblasts. This is flow cytometry plot of TALL. We have cells in the red which are positive for CD5, 7, and 2. So this is TALL. So next is the Ashwin. Ashwin, can you tell us quickly about a few important prognostic factors in ALL? Ashwin is not there. Aryan Bansal. Deepika. Yes, Ashwin. Yeah, there you can answer this. Deepika from the Kartik Pendale. So somebody wants to take up this question. You can mention 3 or 4 prognostic factors, important prognostic factors. Maybe.
Sir.
Sir, age.
Okay.
And sex, age, sex, ethnicity, L1 form has good prognosis, and hyperploidy has good prognosis compared to hypoploidy. Female have better prognosis, and whites have better prognosis. L1 form has better prognosis than L2 and L3.
What about the age?
So 2 to 9 years has better prognosis, and less than 1 year or more than 10 years has bad prognosis.
Okay. Okay, good. So what about the WBC count?
So 50,000.
Sir, more than 1.
Greater than 1 lakh.
1 lakh bad prognosis.
Okay. Good. Okay. So we will end the session here. So, I hope you learned something from this session. So do you want to ask any questions? Or do you want to say something before we close this session? I think we have another session at 3:30 also. Practical. So you want to ask something? Say something.
Yes, sir.
Yeah, I've been telling me.
So are we expected to be able to understand a flow cytogram?
No. It's just to make you see what just to give a broad idea. No, you don't have to interpret or you just have to identify that it's a flow cytogram. It's your flow cytogram. That's it. Or if you don't have to make any diagnosis or any deeper understanding, it's not necessary. You just have to know the test. That is enough. Know the name of the test. That is enough. Okay.
All right, sir.
Know some markers. That is enough. The common lineage markers. Hello. Okay. Okay. Thank you. We'll leave this session.